So for the next presentation, I have the pleasure of knowing one of our speakers since we were both advanced trainees. I'm delighted that he's here to talk to us about BK virus. Dr. Ryan Gately is a transplant nephrologist here at the Princess Alexandra Hospital. He's also currently undertaking a PhD through the University of Queensland entitled Novel Statistical Methods for the Assessment of Complications After Kidney Transplantation. And importantly, some of his work has focused on the incidence, risk factors and impact of BK polyomavirus in the kidney transplant population. His co-presenter, Dr. Laura de Souza, is our fantastic kidney transplant fellow this year. I'd like to invite them both to the stage. Thank you.
Thanks very much, guys, for inviting me to talk. Great setup as well. You put in a lot of work. It's very impressive. Like Lana said, I'm doing a PhD in transplantation. Initially, a lot of my work was on BK and then sort of evolved a bit more statistics. And Laura is our transplant fellow at the moment as well. And she's going to present some BK cases to try and put this in context, because I think BK is usually just the realm of the nephrologists. So I don't know, do any of the other transplant physicians come across it at all or have heard of it? And even the ID guys, I guess, don't manage it so much, because the management of this is usually immunosuppression reduction. So the nephrologists are very cautious looking after this. So most of the work that we've done has been on the epidemiology of BK, particularly in Queensland. All our BK testing goes through the Royal for the whole state, so we can get access to that. Just a bit about the background. So it's a DNA virus. It was first discovered in the 70s in a transplant patient in the UK, where they found characteristic findings on the histology. Most people in the Australian population would have been exposed to BK at some point, so about 90 to 95%. And usually it doesn't cause any issues at all, just an innocuous infection as a child. And then in the setting of immunosuppression, particularly in kidney transplant patients, it reactivates and causes issues. So by issues, I mean asymptomatic kidney dysfunction, really. So there's no actual symptoms. Usually there's no symptoms with this. And it is detected on routine screening, which we do in all kidney transplant patients. So there's a protocol. Here we do monthly to 6 months, then every 3 months to a year, and then every 6 months out to 2 years. And then we don't screen anymore. And whether or not that's the right thing is hard to know, because there has been a few cases of late BK detected here, even out to 5 or 10 years. So sometimes people do it when you pick up graft dysfunction later on and there's no other obvious cause for it. So the virus is usually first detectable in the urine, and then subsequently detectable in the blood, and then finally detectable in the graft itself, with varying degrees of severity or increasing degrees of severity. Previously, they used to do urinary screening, which was very sensitive but not specific at all. So now the guidelines would just recommend purely blood testing for screening. These rates are quite old and quite broad, the ones on the left. So viruria and viremia are much more common than BK van, which is BK virus actually infiltrating the graft itself. These graphs on the right, that's our Queensland data. The top one is viremia. So you can see it peaked about maybe 2013, 2014, and that's 30% of patients having a detectable level above 1,000 copies per mil at a single point. And then it's come down from there. And you can see the prevalence of BK van tends to be steadily declining pretty much since the start of our records, which was about 2005 or 2006. The BK van decreasing probably isn't reflective of reducing rates of BK virus, just that it has been picked up more on screening as opposed to actually until the point where it's so bad that you detect it with graft dysfunction in the actual graft. Specifically at the PA, there's 2 things that have been implemented in the last 3 or 4 years, which may have affected rates. A quicker reduction in the prednisone post-transplant routinely. So now we're bringing it down to about 10 milligrams at about 6 weeks. It used to come down a bit slower. And the other The other interesting thing is urethral stents are a known risk factor for BK as well. So they're routinely put in at the time of transplantation. Previously were taken out at about 6 or 7 weeks. Now they're coming out about 3 to 4 weeks. So that maybe might have also contributed to our reduction in rates. This is all of Australia, and just a comparison of the cumulative incidence over the years. So the lowest line is the most recent era, 2015 to 2019. Again, just indicating that perhaps it's not as common to diagnose BK on biopsy now as opposed to blood. This is a spaghetti plot of all positive BKs in Queensland. Over the last 10 years, I think. The red line is a smooth mean of the all results. So you can see that the highest is just after 1 year, and it does, although the mean remains positive, I guess the point after 2 years is that people are usually only checking it if it is positive. So it's a bit deceptive, this graph, but most of the disease is in the first 2 years. And now we have some cases with Laura.
Hi, everyone. Thank you. We've just got a couple of cases just to highlight our experience of BK over the last couple of years. And as Ryan mentioned, we do routinely screen for BK. In the acute transplant setting, we would normally check for it at the 1 month and 2 month marks, and then often after that, they are discharged back to their own home nephrologists, and the screening sort of recommendations are continued from there. The first case to mention is a 59-year-old gentleman, background of polycystic kidney disease, had a transplant in February of 2017. Average risk, unsensitized, had immediate graft function, and the 1 month BK screening was negative. And then on the 2 month screening in April, the BK virus PCR in the serum was detected. And the graph here just demonstrates, I guess, the timeline of events from here for the following couple of years. So as Ryan mentioned, the initial management at the first detection in the serum PCR was to adjust the immunosuppression. So the tacrolimus and mycophenolate were reduced. And over the course of the subsequent screening for the next couple of months, the PCR increased, and so a biopsy was completed, which demonstrated BK in the actual graft as well. So at that time, leflunomide was commenced, but unfortunately there were significant complications with this, including significant neutropenia requiring washout of the drug, and that had to be ceased. So subsequently, IVIG was commenced. And you can see from there, there was a significant decrease in the BK titer, but in the subsequent year, this climbed again. A repeat biopsy was completed, which showed features of BK in the graft as well as rejection. And so at that time, the patient received treatment with for antibody-mediated rejection with Plex and plasma exchange and IVIG immunoglobulin as well. So despite that, you can see that the BK titer did sort of plateau off, but the creatinine continued to rise over the subsequent couple of years. And unfortunately, the patient progressed to requiring return to hemodialysis despite that treatment. In the subsequent couple of years, so October 2023, the patient had developed macroscopic hematuria reported to their home nephrologist. And this was investigated amongst the public and private sectors, and went on to have a cystoscopy, which unfortunately confirmed micropapillary bladder malignancy. didn't mention at the back, towards the end of following this episode of rejection, the immunosuppression was switched over to try and help manage the BK, which I guess the point in this case is that despite management of the immunosuppression, reduction in the overall levels and switching over to alternative agents and seemingly reassuring low-level viremia, there are associated complications that we do need to be aware of in the subsequent years following that. So the patient now is looking towards potentially a cystectomy and possibly graft nephrectomy. The second case is similar, to highlight a couple of years later. A 60-year-old gentleman transplanted at the end of 2019, second graft, but otherwise no particular other risks. Had delayed graft function requiring dialysis at the beginning, and so it had a biopsy to clear the air with that. Didn't show any rejection, had actually had the immunosuppression reduced for leukopenia. And again, the serum BK viral PCR was undetectable at the 1 month mark. So again, just in terms of the course from there for the subsequent years, BK viremia was noted sort of a couple of months following that. The immunosuppression was reduced, but unfortunately the titers continued to climb. So biopsy was completed and again showed BK in the graft. Changes were made to the immunosuppression, which, as you can see, did result in a drop in the BK titers in the serum. But unfortunately, the graft progressed to climbing creatinine despite treatment and despite the falling BK titers. And then unfortunately in the subsequent years to that, following also the return to hemodialysis, unfortunately the patient also developed a bladder malignancy with a multifocal solid ampullary tumour confirmed on histopathology as being associated with BK virus. This is a more recent case, 57-year-old gentleman, also polycystic kidney disease background with average risk and standard induction, and he had immediate graft function, no complications in the immediate postoperative period. Also had serum BK virus negative at the 1 month screening, and had a few investigations early on in the piece for a rise in creatinine a few months after his transplant. And had, again, at the 2 month mark, serum BK viremia detected at 10 to the 4. So this is his sort of course in the following couple of years. So again, starting with the reduction in immunosuppression and replacement of tacrolimus with cyclosporin, had a biopsy which showed both BK in the graft as well as features of rejection, so had been pulsed with methylpred, and despite that really had no drop in the titers. So this patient went on to have immunoglobulin as well as T-cell therapy, which I think is being spoken about a bit later in the day, so I won't touch too much on that. And you can see following that there was a nice drop in the BK titer, but still at detectable levels, and the creatinine really hasn't settled. So the patient completed their T-cell therapy and has had the IVIG weaned, and this patient is followed up in a regional centre, but we would liaise closely with them if things sort of change. But this is where we're up to sort of in the recent months, January of this year. So it will be interesting to see what happens to him in the subsequent years. I suppose myself reviewing the cases, the real take-home messages from that are that the screening, points are important and picking it up early, and obviously just having the awareness that a persisting low level of BK viremia, although may seem somewhat benign, obviously need to be vigilant for longer-term complications in our patients, and hopefully there are some promising therapies on the horizon, because at the moment we don't have all that much other than reducing their overall immunosuppression. hand back over to Ryan.
And sorry, just a quick few slides, thanks, Laura, on risk factors and stuff. So a lot of the cases Laura discussed would have had these risk factors. Age is a big one, both in the recipient and the donor. The hazard ratios is there. That's from our own ANS data analysis, looking at all the BK van in Australia. So you can see both age for donor and recipient are quite strong risk factors. And I think most of your guys were on the older spectrum. So it's not linear. The children young children have a low risk. So essentially the extremes of age have higher risk, both in donors and recipients. Male sex in the recipient is a strong risk factor as well. And some of the interesting transplant related factors are, well, I say interesting, but I think they're interesting. I don't know if anyone else thinks they're interesting. The difference in ethnicity between donors and recipients is thought to be a risk factor, and that may be because there's a few different subtypes of BK. So usually there's about 4 different subtypes, and a person will have immunity to their own subtype. And if someone from a different geographical region donates a kidney, they may have a different type of BK subtype, which the recipient will not be immune to. Tacrolimus use has been shown to be a strong risk factor in a few papers, and ours support that. And the other one that was shown in the American registry study as well was transplantation in a lower volume center. It's a bit hard to explain. I don't know, does that reflect biopsy practices or lack of screening? There's a few potentials for that. This is using these risk factors, we created a predictive model to try and pre-transplant predict the incidence of BK. So it hasn't been published yet, but hopefully soon. So you can just put in your different risk factors, and it'll give you an idea of the probability of developing BK within the first 2 years. This isn't live, unfortunately. I thought it was too risky to try and run a live website during the talk, but it is online if anyone is very interested. And the risk factors are most of the typical ones. We have age, sex. This uses a discrete time model, which divides time into 4 discrete periods between 0 and it was initially 2 years, but we increased the length up to 5 years. So instead of using a traditional survival analysis model where time would be continuous, this has used a discrete model, which offers a few advantages. It makes it easy to explain as well. So you can say that you've got an X% chance of developing a complication within this time period, as opposed to trying to explain hazard ratios or something like that. And the other advantage as well, which I haven't really touched on yet, is rejection is a very important risk factor and complication of BK. So rejection pre-BK treated with more immunosuppression, which obviously increases the risk of BK. BK before rejection is usually a reduction in the immunosuppression, leading obviously to the risk of rejection. So rejection is time varying, and the discrete model handles time varying variables quite well. And that's just sort of a graphical representation of what I've talked about. So the usual course is you get BK, you reduce, I shouldn't say usual, but sometimes the course is get BK, reduce the immunosuppression, increase the risk of rejection, more immunosuppression, round and round. The impact of BK is bad. So again, this is BK van from the Australian registry study. So 1.75 hazard ratio for all cause. Death censored is a lot higher at 2.5, probably because of the higher incidence in older ages. From a joint model, which I'll show the graphs next, that jointly models both a survival model and a linear mixed model. So you can do a time series plus survival analysis, and allows you to try and judge the impact of a longitudinal change in BK. So I'll talk about that one in the next slide. And then just touching on the rejection again. So in those who had biopsy proven BK, at least 40% of them had 1 episode of rejection either before or after. So a very high proportion. And then the other potential complication is bladder cancer, which Laura's talked about. That one isn't as well studied and mostly confined to case reports, but from our local cases, it does tend to be elderly males with either very high initially or else persistent BK. So we're hoping to collate our cases and try and determine some risk factors for the actual malignant potential of BK. And this is the joint model that I was talking about. So a combination of a survival model, standard survival model, and a standard linear mixed model, which models BK over time. And the advantage of this, it allows you to make dynamic predictions. So if you see the top one, this would be the left part of the graph is actually BK results. So this hypothetical patient has had no BK up until about 2.5 years. And then starting at 2.5 years, you're predicting their survival for the next 7 or so years. So you can see that if they have no BK up to 2.5 years, then 7 years after that, their survival probability is about 0.75 or so. But then, somewhat unfortunately, they develop really bad BK, I don't know why, at 4 years and up to log 5 or so. And you can see the impact this has on their survival probability of the graft. So it drops right down to 0.4 in about 5 years' time. So BK, even most of the previous stuff has been on the impact of biopsy BK, but this is viremia. So viremia does have an impact as well. And treatment we briefly touched on, there really isn't many agents for treatment. Almost all of the management is immunosuppression reduction. These guidelines were just released online earlier this year, and they haven't really changed much beyond saying that removing most of the agents we used to consider useful. So no strong recommendation for which to do first, but reduce either the antimetabolite or the CNI by about 50%. Initially, repeat 2 weeks and see how we go. The other agents they said we could consider IVIG and cyclosporin conversion. We use a bit of cyclosporin conversion here. It's thought to certainly doesn't have the risk factors for the development of BK and thought to actually have a direct antiviral effect as well. And then these agents, which used to be used a bit more, are now not recommended. And the last thing I was going to say is we are part of a randomized trial in BK being run out of Westmeath in Sydney. Haven't recruited that many from the PA, but hopefully coming. We're hoping to get 200 patients, and essentially the intervention is standard of care versus standard of care plus IVIG. With an inclusion criteria of about 5,000 copies of BK. And the interesting thing about, I've been saying interesting a lot, I think it's interesting. The difficult thing about getting an outcome for a virus trial is how to choose that outcome. If you choose BK alone, it sort of misses the point because you can reduce you could stop your immunosuppression theoretically and the BK would go away, but you would lose your graft quite quickly. Conversely, you could keep the immunosuppression high. You would probably have good graft function for a period, but your BK would run rampant and then a year or two you'd lose. So this composite ordinal outcome tries to amalgamate all the important bits in a hierarchical fashion to give a ranked outcome, which is a bit controversial, but it was thought that this was the only way that you could get, or the best way to get a BK outcome for the trial. And you can see the lower 3 levels of the outcome are made up of the degree of immunosuppression reduction required to adequately suppress the virus. So there'll probably be a large portion of the patients who end up in those 3. So I think that's the last slide. Thanks again for inviting me to talk, guys. So if there was any questions for Laura or myself, I'd be happy to answer.
Thank you very much, Ryan and Laura. I think in the interest of time, we'll have to keep moving. Is that right? Okay. Apologies. Maybe some questions at the end.
Perfect.
Thank you.
Thanks.